So this was a lengthy question, but a very easy question. Which statement is true, not true? So see carefully, not true about clinical trials. Okay. So other statements are directly what is done, but it is very clear. Phase 4 trials are conducted before the regulatory approval. So we all know phase 4 are post-marketing. Post-marketing. So before the approval, they cannot be done. So this is a wrong statement. So it is the answer. Okay. That's after NDA it is done. Now if we see, phase 1 trials are done in small number of healthy volunteers. So small number, there is no fixed number. Small number may be 20, 30, 50, kitne bhi ho sakte hain, small number. So it is done mainly to adjust optimal dose, assess safety, and detect any potential adverse effects in human for the first time. बेटा adverse effects तो पता लगेगा ना, phase 1 में ही तो adverse effect पता लगेंगे. So we are giving a particular dose and we are seeing what toxicity is occurring. Adverse effect तो वही होते हैं ना, safety और adverse effects तो एक ही तरीके से, कान को ऐसे पकड़ लो या ऐसे पकड़ लो, है ना. Okay. Then phase 2 trial involves several hundred patients. That can be right. Usually 100 to 200 तक patient हो सकते हैं with the target disease primarily aimed at determining therapeutic efficacy. Primary aim is efficacy, also continuing safety. ये भी सही है. Phase 3 involve large scale studies. Yes, up thousands of patients are there. And they are used to confirm the therapeutic effectiveness. Confirm करने के लिए होते हैं. Yes, it also compare the new intervention with the placebo or standard control, and also and collect information that drug should be safe. Because after phase 3 we have to approve the drug. Yes, maximum failure phase 2 में होता है. Yes, phase 2 में dose ranging studies कर सकते हैं. तो but phase 1 में we come to know broadly about dose range. बट उस रेंज की स्टडी करते हैं फेज 2 में. यू ट्राई टू अंडरस्टैंड वन थिंग. फेज 1 में पता लगता है कि ये डोज 50 से 500 मिलीग्राम में दे सकते हैं. ठीक है, वो 50 से लेके 500 तक जो स्टडी करते हैं वो फेज 2 में करते हैं. वो डोज रेंजिंग स्टडीज कहते हैं. यू अंडरस्टैंड? फेज 2 में डोज रेंजिंग स्टडीज करते हैं. दैट मींस डिफरेंट डोजेस देके स्टडी करते हैं. ठीक है. एडीआर इन फेज 4 ना बेटा, एडीआर इज डन इन ऑल द फेजेस. ठीक है. लॉन्ग टर्म एडवर्स इफेक्ट्स आर डन इन फेज 4. एफिकेसी ट्रायल इज फेज 3. करेक्ट. क्लियर है? इसमें कोई प्रॉब्लम तो नहीं है. सो दिस इज अ डायरेक्ट क्वेश्चन. अगर आपको नहीं भी आता था तो आपको इससे पता लग जाएगा. दिस इज अ बिग हिंट. ओके, चलिए. क्लिनिकल ट्रायल इज वेरी इंपॉर्टेंट एमसीक्यू टॉपिक. देख लेना ठीक से. नेक्स्ट क्वेश्चन इजी वन. नाइट्रोग्लिसरीन के बारे में विच इज नॉट ट्रू. नाइट्रोग्लिसरीन विच इज नॉट ट्रू. ध्यान से पढ़ना है. नॉट पूछा है या ट्रू पूछा है. विच इज नॉट ट्रू. ओके ओके. I am not able to read your name. Akshagna. So nitrates primarily cause vasodilation by increasing intracellular nitric oxide. We know nitrates are broken down from NO, and which activate guanylate cyclase and increase cyclic GMP that cause vasodilation. That we all know it is a true statement. Nitrate predominantly cause venodilation. Yes, they mainly decrease preload, venodilation, and when we dilate the veins, the work of the heart decreases. So myocardial oxygen demand decreases. So they are useful in angina. Nitrates are known to cause reflex tachycardia. Yes, that's also true. Any vasodilator can result in reflex tachycardia. So that's why in angina, we usually give nitrate with beta blockers or calcium channel blockers. So it can be counteracted by beta blockers. Lastly, nitrates can be used cautiously in patient on phosphodiesterase inhibitors like sildenafil. No, they cannot be used even cautiously, because they can cause severe hypertension. Person can end up in emergency. So they are absolutely contraindicated. And what is there? With all the phosphodiesterase inhibitor like sildenafil, etc., minimum 24 hours gap should be there. Minimum 24 hours gap. Suppose a person has taken nitrate today, person cannot take sildenafil for 24 hours. And the long-acting drugs like tadalafil, that need to be spaced for 48 hours. ठीक है, तो 24 घंटे से पहले तो दे ही नहीं सकते. तो 4 hour अपार्ट देंगे तो पर्सन विल एंड अप इन इमरजेंसी. सो दिस इज अ रॉन्ग स्टेटमेंट. नाइट्रेट एंड सिल्डेनाफिल इंटरेक्शन इज वेरी वेरी इंपॉर्टेंट फॉर एमसीक्यूज. ठीक है. वैसे आपको अदर 3 यू मस्ट हैव रूल्ड आउट ना. आई होप इट इज क्लियर. ग्रेट. तो रूल आउट करके भी आप आंसर कर सकते हो. कॉम्प्लिकेशन बेटा, देयर विल बी सिवियर हाइपोटेंशन. ब्लड प्रेशर में रीच इवन 0. सो मिनिमम 48 आवर्स कहते हैं, अप टू 72 आवर्स तक वेट करना चाहिए. कृतिका मिनिमम 48 आवर्स कहते हैं, मिनिमम, द वर्ड इज मिनिमम। क्लियर बेटा? नाइट्रेट तो वेसोडाइलेशन ही करते हैं ना। एनी वेसोडाइलेटर विल कॉज रिफ्लेक्स टैकिकार्डिया। वैभव, कोई भी वेसोडाइलेटर हो, when the blood pressure decreases, then the body compensates by increasing sympathetic activity that cause tachycardia. ठीक है, चलिए नेक्स्ट क्वेश्चन, another long question. So which statement is not true? Again, not true about antihypertensive drugs. Not true. AC inhibitors are particularly beneficial in diabetic patients with hypertension due to ability to reduce intraglomerular pressure and slow the progression of diabetic nephropathy. Yes, absolutely right. AC inhibitors are very, very good drugs for diabetic patients, decrease the risk of diabetic nephropathy. Calcium channel blockers like amlodipine are effective in lowering BP and particularly useful in elderly patients, but they can cause peripheral edema as a side effect. Yes, it's absolutely right. Now, you must be knowing the British antihypertensive guidelines. हम यूजुअली जो फॉलो करते हैं वो अमेरिकन गाइडलाइंस जो फॉलो करते हैं. इन ब्रिटिश गाइडलाइंस व्हाट दे से, इफ द पर्सन इज यंग लेस देन 45 years, give A or B. Whereas the person is elderly more than 45 years, then give C or D for treatment of hypertension. Clear? So young patients में AC inhibitors or beta blockers, elderly patients में calcium channel blockers or diuretics. Clear? So that is why British guidelines, but we do not follow those guidelines, but those guidelines say that these are good for elderly patients. Clear? So calcium channel blockers like amlodipine are good for elderly patients, and we all know the side effects are peripheral edema. Ankle edema is the side effect. Ankle edema. Okay? Beta blockers such as atenolol are considered first line drugs in hypertension with diabetes. Right or wrong? Wrong. Beta blockers are contraindicated in diabetic patients. Non-selective are absolutely contraindicated, but even cardioselective should be avoided because they will cause, number one, mask the hypoglycemia symptoms, and second, they can prevent the reversal of hypoglycemia, and further long-term use can lead to hyperglycemia also. Okay, so beta blockers are contraindicated in diabetics. They are not the first line drugs. Thiazide decrease blood pressure by promoting natriuresis, correct? But long-term use may worsen glucose tolerance and lipid profile. We all know thiazide cause hyperglycemia, hyperlipidemia, hyperuricemia. So this statement is also correct. Clear? Vidya is asking, can we use in euglycemic drug? What is the meaning of that statement? I am not able to understand. What is first line in diabetes with hypertension? Beta AC inhibitors. AC inhibitors are first line drugs. Okay. Chal. Next question, another very long question. ये किसने सही किया ये बताओ. Can we use beta blocker in euglycemic drug? Beta, I could not understand the meaning. What is the meaning of euglycemic drug? Great, great. सब लोग बहुत इंटेलिजेंट हैं. I thought कि इसमें तो कोई ना कोई फंस जाएगा, but still. Now see, the question is which is not true. Which statement is not true about vitamin K antagonist or anticoagulants? Apixaban is a direct factor 10A inhibitor, right? Axaban 10A direct factor 10A inhibitor. That's right. Does not require monitoring. Quickly tell me which anticoagulants require monitoring. Which anticoagulant drugs require monitoring? Monitoring is required for which? Number one, Warfarin, vitamin K antagonist, monitored by PT or INR. Number two, unfractionated heparin, monitored by APTT. Number three, injectable direct thrombin inhibitor like Vivalirudin, Argatroban. They require monitoring by again APTT. So rest of the anticoagulants, including low molecular weight heparin, fondaparinux, and new oral anticoagulants like dabigatran and hexabans, they do not require monitoring. That is very important. Monitoring is not required. Clear? This we discussed in the lecture also. ये आपको याद करना है because that question is asked. Okay? चलिए. Now, apixaban is 10A inhibitor and do not require monitoring. That's great, correct? Warfarin exerts anticoagulant effect by inhibiting vitamin K epoxide reductase. That is the right statement. Vitamin K epoxide reductase, which help in regeneration of active form of vitamin K. leading to decreased synthesis of factor 2, 7, 9 and 10. Correct or wrong? This is wrong. Decreasing to decrease activation. Synthesis तो liver में होती है, ठीक है? So vitamin K is required for activation. So which metabolic thing happens when they become activated? Activation के लिए क्या चाहिए होता है? That is the biochemistry question. How vitamin K become active? Yes, gamma carboxylation. So these result in gamma carboxylation of glutamate residues in the clotting factors. तो गामा कार्बोक्सिलेशन करता है, उससे वार्फरिन विटामिन के बिकम एक्टिव. सो दे डू नॉट डिक्रीज प्रोडक्शन, दे डिक्रीज एक्टिवेशन. सो दिस इज द रॉन्ग स्टेटमेंट एंड इज द आंसर. Next question. Next, anticoagulant effect of warfarin begins after 4 to 5 days. That's correct. That's why initial bridging with heparin is required. Dabigatran is direct thrombin inhibitor, right? And anticoagulant effect reversed by idarucizumab. Remember, dabigatran we discussed. DA for dabigatran, or we can say dabigatran दारू की तरह oral पीते हैं, oral. So it is oral anticoagulant, and antidote is idarucizumab. Clear? I hope अगर आपको ये नहीं भी पता था तो seeing the options you could have ruled out, because apixaban वाला right है, 4-5 दिनों वाला right है, and idarucizumab वाला भी right है, ठीक है? Although this also seemed to be right, but catch word here is synthesis. ओके, एंड आई एम वेरी सॉरी कि इतने लंबे क्वेश्चन में भी इतना छोटा सा कैच देना है, तो मतलब नाइंसाफी है. आई नो नाइंसाफी है, बट कभी कभी नाइंसाफी करने का मन करता है ना. बेटा 2, 7, 9, 10 सेम रहता है. यस, 2, 7, 9, 10 सेम रहता है. ओके, चलिए नेक्स्ट क्वेश्चन. अगेन विच इज नॉट ट्रू. सो दे आर आस्किंग विच इज नॉट ट्रू. सो ऑप्शंस: नाइट्रोफिरेंटोइन is commonly used in uncomplicated lower UTI. Yes, it is almost drug of choice, and is generally avoided in renal impairment. Yes, because any drug which is used in UTI usually will be avoided in renal impairment, because sufficient concentration will not reach the urine. Okay, so this statement is right. Fluoroquinolones like ciprofloxacin act by inhibiting bacterial DNA gyrase. Yes, they are DNA gyrase inhibitors, leading to inhibited DNA replication and associated risk of tendinopathy and QT prolongation. That's also right. Clear? That's also right. Next thing, aminoglycosides such as gentamicin inhibit bacterial protein synthesis by binding to 30S. This is also correct. But they are considered safe for use in pregnancy. That is wrong. Aminoglycoside can cause, what they cause in pregnancy? Ototoxicity. Yes, they cause sensory neural hearing loss. So that is a wrong statement. Then cotrimoxazole, which is sulfamethoxazole plus trimethoprim, act synergistically by sequentially inhibiting folate synthesis. Yes, sulfamethoxazole or sulfa drugs inhibit the first enzyme, folic acid synthase, and trimethoprim inhibit the second enzyme, dihydrofolic acid reductase. Okay, given in ratio 1:5, everyone knows. Okay, and are used in UTI. That's right. It can cause bone marrow suppression and megaloblastic anemia. That's right. Bone marrow suppression can be caused by sulfonamides, whereas megaloblastic anemia is caused by trimethoprim because it inhibits dihydrofolic acid reductase. Clear? So this is also right. So the wrong statement is this: aminoglycosides are not safe in pregnancy. Kalpita Shukla is asking amikacin adverse effect. But all adverse effect of aminoglycosides, that means nephrotoxicity, ototoxicity, neuromuscular blockade, and teratogenicity. All are adverse effects of aminoglycosides. Okay. Drug of choice for complicated UTI. Beta, if it complicated UTI, we usually give meropenem like drugs. ठीक है, पहले हम ceftriaxone देते हैं. So complicated UTI में usually the treatment should be guided by कल्चर एंड सेंसिटिविटी. कल्चर सेंसिटिविटी से ट्रीटमेंट होनी चाहिए, बट अगर कल्चर सेंसिटिविटी नहीं कराया है एंड कॉम्प्लिकेटेड यूटीआई है तो फर्स्ट वी विल ट्राई सेफ्ट्रायोक्सोन. If the patient is stable cardiovascularly, we can give ceftriaxone. But if patient is unstable, BP वगैरह लो है, शॉक में है, then we will directly give meropenem like drugs. ठीक है, ये याद करो. Clear? Complicated वाले. Yes, any UTI in male is complicated. तो सेफ्ट्राक्सोन दे सकते हैं, फ्लोरोक्विनोलोन्स दे सकते हैं. सो डिपेंडिंग अपॉन द कल्चर सेंसिटिविटी यूजुअली दिस इज डन. क्लियर? नाइट्रोफुरेंट एंड ओरल है, यस. फ्लोरोक्विनोलोन्स आर अवॉइडेड इन चिल्ड्रन, यस बेटा, अवॉइडेड इन चिल्ड्रन. बेटा ट्राइमेथोप्रिन सल्फामेथोक्साजोल डू नॉट कॉज G6PD deficiency but avoided in patient with G6PD deficiency. Okay, चलो another long question, again not true. इन्होंने सारे इकट्ठे डाल दिए नॉट ट्रू वाले जितने भी मैंने क्वेश्चन बनाए. दे हैव गिवन. अगर ब्रेक ब्रेक में देते एक लंबा एक छोटा क्वेश्चन तो टेंशन नहीं होती है ना. Yes, Vishnu, I'm saying that fluoroquinolones should be avoided. If you have listened to my main lectures, I have told that fluoroquinolones, there is a catch. They should be avoided in children and pregnancy. But एक star mark लगा दिया. Star mark means conditions apply. They said that conditions apply. That means fluoroquinolones can be used as absolutely required. तो इसका फायदा उठा के सब बच्चों में देने लग गए. But they should be avoided. Okay, चलिए. Not true. Risperidone. Risperidone, बेटा you know the answer. I know you know the answer because शिप्रांटी सबको याद होगा, ठीक है. But what is important is to see other options because they are potential MCQs. Okay, risperidone can elevate prolactin levels due to D2 receptor blockade. Now, why you need to know this? Risperidone is the strongest D2 blocker among atypical. ठीक है, टिपिकल वाले सारे D2 ब्लॉक करते हैं, but atypical में strongest D2 blocker is risperidone. So it can cause galactoria, it can cause EPS also. EPS can also be caused by risperidone. Okay. Second, clozapine has the lowest risk of EPS. That is absolutely right. Clozapine do not block D2 receptors, but it cause agranulocytosis and myocarditis. सबको याद है ना, क्लोजा, ठीक है. मैं तुम्हें बर्बाद कर दूंगी तो ये बर्बाद कर देती है, ठीक है. agranulocytosis and myocarditis. Then क्यूटापिन के नाम में लिखा है QT, so it cause QT prolongation. क्यूटियापिन cause QT prolongation. Remember QT prolongation कौन सी एंटीसाइकोटिक्स करती हैं? Antipsychotic drugs causing QT prolongation. So that is remembered as Hello QT. Hello QT. Hello QT. Hello QT. And you all know Zara. So Hello QT Zara. Okay. So haloperidol, quetiapine, and ziprasidone. Haloperidol, quetiapine, ziprasidone, and thioridazine. You can remember one more if you want. Thioridazine. They can cause QT prolongation. QT prolongation. Then ये शिप्रांटी everyone knows. I hope everyone knows शिप्रांटी. Aripiprazole and ziprasidone. So they do not cause weight gain. This is the opposite thing asked. They do not cause weight gain. So this is a wrong statement. Wrong statement. Aripiprazole and ziprasidone cause minimum weight gain, even lesser than typical drugs. Typical से भी कम weight gain करते हैं. Okay. I hope no one has made this question wrong. So one advantage of giving these long options is that we have discussed many more points which may have forgotten otherwise. ठीक है, तो एग्जाम में आज आपकी preparation हो रही है, you are discussing many more points. Okay, now next question. So this is a question about antidepressant drugs. Another not true, which is not true about antidepressants. Not true. SSRIs like sertraline, they increase synaptic serotonin level. Yes, they inhibit the reuptake of serotonin. So more serotonin will be there. And considered first-line drugs, yes, they are drug of choice. So that is a correct statement. TCAs like amitriptyline, what they do? They inhibit reuptake of norepinephrine and serotonin. Yes, they are non-selective. They inhibit both. It is true. But their use is limited due to their anticholinergic side effects, sedation, and cardiotoxicity in overdose. Yes, even metabolic acidosis can be seen. So this statement is also true. MAO inhibitors increase the level of monoamines by inhibiting their metabolism. Yes, MAO breaks catecholamines and require dietary restrictions. Yes, MAO inhibitors can cause cheese reaction. Cheese reaction can occur. So that is also true. Now, bupropion is norepinephrine dopamine reuptake inhibitor. That is a right statement. NDRI. Norepinephrine is right. The bupropion is right. NDRI. That is frequently associated with sexual dysfunction. That is a wrong statement. Remember, I told you that sexual dysfunction mainly occur due to excessive serotonin. Serotonin के कारण होता है. Okay? So if a drug is not increasing serotonin, it is unlikely to cause. So that's why most of the newer drugs, or we can say atypical drugs, they have minimum sexual dysfunction. So sexual dysfunction करता है is a wrong statement. So that is the catch. That is the catch. Clear? But not only bupropion and mirtazapine, almost all newer drugs, ज्यादातर yes it cause seizures as side effect. Major side effect of bupropion is seizures. Side effect of bupropion is seizures. And it is used for one more purpose, smoking cessation. PO है ना, it is used for smoking cessation. Smoking cessation. But it is contraindicated in which psychiatric disorder? It is used for smoking cessation, but contraindicated in which psychotic disorder? Just contraindicated in patient with bulimia. Bulimia के patient में contraindicated. Okay? No beta, venlafaxine, desvenlafaxine has almost similar chances of causing sexual dysfunction. बहुत ज्यादा difference नहीं होता है. Significant sexual dysfunction is seen. No? Because they also increase serotonin. Which drug cause weight loss? You are saying? Bupropion, yes, with naltrexone it can cause weight loss. Yes, bupropion can cause weight loss, but usually given with naltrexone. अकेली नहीं काम करते. चलिए, next question. Now, anyone made this question wrong? So see the question. Question here is: patient is having GTCS over 7 minutes, and more than 5 minutes means it is status epilepticus. Status epilepticus. So there is seizure, and there is no recovery. Another seizure occur. Another seizure occur. Okay. Brain MRI is normal, so patient is not on any chronic medication, okay, but they are planning pregnancy. Okay. So what is the long-term anti-epileptic therapy? So read carefully. They are not asking the treatment of status epilepticus. ठीक, तो स्टेटस एपिलेप्टिकस देख के आपको लोराजिपाम आंसर नहीं करना है. लोराजिपाम कैनॉट बी द आंसर because they are not asking the not asking the immediate treatment. Immediate treatment, yes, is lorazepam. Lorazepam is drug of choice, but they are asking long-term treatment. Long-term treatment, so lorazepam answer nahi. Then valproate otherwise would have been drug of choice had they not been planning pregnancy, because valproate is drug of choice for GTCS, but pregnancy plan nahi kar rahe, so valproate is contraindicated because it causes teratogenicity. Lamotrigine and levetiracetam, we all know they are drug of choice in pregnancy. Yeah? They have low risk of GTCS. Then carbamazepine, effective for GTCS and commonly used for first-line therapy, more favorable teratogenic profile. No, carbamazepine also has good teratogenic effect. So, although lesser than valproate, but still significant teratogenic effects are there. So, we will not prefer carbamazepine, we will prefer lamotrigine. Remember, L for lamotrigine, L for levetiracetam, L for least teratogen. So when the patient deliver, after that, we can see if the seizures are controlled, then no need to change. But the seizures are not controlled well, then obviously we will change that. So changing the drug or not depend upon the therapeutic efficacy, not on pregnancy status. Okay. Next question. So beta antipsychotics are best for bipolar disorder, not for epilepsy. Karanbir Singh, antipsychotics are drug of choice for bipolar disorder in pregnancy. They do not have anti-epileptic effect. This question was epilepsy. Okay. Next question. So, person was taking tacrolimus, mycophenolate, prednisolone, and gabapentin. 4 drugs are being taken. So, how the patient present? Patient present with tremors, headache. That means neurotoxicity is there. Tingling, neurotoxicity is there. Hypertension is there. BP is high. Then serum potassium level is elevated. More than 4.5 is elevated. And serum creatinine is also level. That means nephrotoxicity. So which drug cause all these side effects? Yes, cyclosporin and tacrolimus. Cyclosporin and tacrolimus. Quickly revising the side effects of these. These are nephrotoxic. These are neurotoxic. These are hepatotoxic. So nephrotoxicity, neurotoxicity, hepatotoxicity. And they increase everything, means they increase blood pressure, hypertension. They increase blood sugar. They increase serum lipids. And they also increase potassium. Yeah. So they increase everything. So these are the important side effects. Now, what is the major difference between the side effects of cyclosporin and tacrolimus? Difference kya hai? These are the common side effects. Yes, cyclosporin also result in gum hyperplasia, whereas tacrolimus do not. Tacrolimus do not cause gum hyperplasia. Hirsutism, gum hyperplasia, both mainly gum hyperplasia पे question आता है. Tacrolimus do not. Clear? So that is important. Now mycophenolate, the main side effect is bone marrow suppression. Mycophenolate cause bone marrow suppression. And what is the mechanism of mycophenolate? ये भी कई बार क्वेश्चन पूछ लेते हैं. Mycophenolate, what is the mechanism? Yes, it inhibit IMP dehydrogenase. Inosine monophosphate dehydrogenase. IMP dehydrogenase, not synthase, dehydrogenase. IMP dehydrogenase. Sir, can't it be fine tremors because of high testosterone levels? हाँ बेटा, वही हो सकता है. So what is the problem there? That is a manifestation of neurotoxicity, ना? Tacrolimus ही तो आंसर है. What is the problem in there? Okay. Prednisolone and gabapentin, we know they are mainly sedative drugs. These side effects are not associated. Okay. So answer is tacrolimus. Tacrolimus. Okay. नेक्स्ट क्वेश्चन तो बच्चों वाला क्वेश्चन है. बच्चों वाला क्वेश्चन है ना ये तो. आई होप नो वन हैज मेड दिस रॉन्ग. यस, इट इज आंसर ए. Rifampicin is enzyme inducer. It increase the metabolism of warfarin. It become ineffective. So that's very easy. Enzyme induction by rifampicin leading to increased metabolism of warfarin. Okay. Now the more important question is what should be done. अगर ऐसा हो गया तो करेंगे क्या? What is the next step? The question is what is the next step and what we will do for long term basis. Answer these two questions. इस पेशेंट में हम क्या करेंगे? Very good. So all of you are wrong. If a person is having TB, we will not change rifampicin. Rifampicin ज्यादा जरूरी है भाई. Rifampicin नहीं बदलेंगे. That is the catch word. Rifampicin is changed only in HIV patients with protease inhibitors. Okay? So the next step will be add heparin. Bridging जो हमने पढ़ा था ना. So heparin should be added because it will start immediate anticoagulant effect. Immediate anticoagulant effect. Okay? But heparin is given only for 4 to 5 days because effect of warfarin takes that much time. So what we will do two things: increase dose of warfarin and start heparin. Okay? So after 4 or 5 days, when INR become normal, INR what we require therapeutic, then we will stop heparin and continue on warfarin. Okay? So warfarin dose increase is main important thing in long term, but immediately give heparin bridging. Okay? Heparin bridging. So Amanya Solanki is, I think, new to our lectures, and he or she is asking who is Pooja. Okay? So can anyone explain this? A very important MCQ question. So I think मेरा फर्ज बनता है कि I need to tell again. But if Amanya is not able to understand Hindi, then it will be difficult for him or her. Okay? So basically, what we say, no, Richa Pooja can be you or double O anything, है ना? चलो, I understand English. Good. So basically, I commonly keep on telling that read the MCQs very carefully, just like we discussed in the warfarin case, synthesis and activation that change the answer. Okay. So even one comma can change the meaning of the statement. Okay. Like जैसे वो कहते हैं ना कि चलो पूजा करते हैं या चलो पूजा करते हैं. The meaning changes. So whenever you make any question wrong by not reading the question correctly, so we say पूजा हो गया, पूजा हो गया. ठीक है, समझ आ गया? So that's why पूजा is very important for MCQs. Is it clear? तो ये चीज आपको पता होना चाहिए. Next step is to give heparin and long term basis increase the dose of warfarin. Increase the dose of warfarin. Okay.